rid of the wrinkles, have some rejuvenation as the previous speaker spoke about. And the first ever person to actually correct these wrinkles would be a woman who would be looking at her face and actually trying to get rid of her wrinkles, right? So at the outset, I would like to thank the ISA Foundation along with AMA and the Thai Association of Aesthetic Academy. So to begin with, what is this new term, injection anatomy? The surgical anatomy initially went on with the understanding of dissecting layers through a scalpel. But here, if you look at injectable anatomy or the injection anatomy, you kind of venture into a territory with a needle or a cannula, and that works as a camera for you or the eyes for you. You actually venture into a blind spot without knowing where you're going. So an intricate detailing of the anatomy is very essential for you. So basically, it can be defined as the study of regional anatomy as it relates to the surface landmarks and the underlying depth of targeting tissue and vital structures. So the depth is important for you. But if you look at the general anatomy, you would divide the face into various anatomical structures, which you would be aware of based on the various landmarks. If you look at face holistically, it is more or less like a layered concept, right? It starts from the superficial skin, goes down to the subcutaneous fat, then the smas layer, then the muscles, then the periosteum and the bone. It is more or less like a tent, okay? And then if you look at it as a perspective, it might appear as a sandwich with various layers clubbed together, and each one of them holding together with the help of a retaining ligament, which can be looked upon as that toothpick which holds on to the various layers of a sandwich, right? Just like something in this picture, where you see a string of ligaments attaching all the layers from the bone, from the periosteum, all the way up to the skin. So what does it really mean? We have heard a lot about the skin, so I'm not going to get into the anatomy of the skin. But you know, all the superficial treatments, all the mesotherapies happen at the dermal and epidermal layers. Then comes the subcutaneous layer, which has fat. There is a superficial fatty layer, which have certain segmental divisions on the basis of various ligaments present on the face. Then there are deeper layers of fat, which are present basically underneath the orbicularis oculi and various other locations as well. We'll discuss that in the later stages. Underneath the fat is a layer which is more or less like a lamination on the muscles. If you remember buying a cloth from the mall, from the shopping mall, you would see that there is a layer of paper in between the folds. Why do you think that paper is being kept in between those folds, in between the clothes? It is basically to prevent the overriding of clothes so that it doesn't become wrinkled. So God has given us the smas layer or the superficial musculo-eponeurotic system to prevent the overriding of various layers of the face, right? That prevents us from getting the wrinkles. And it is like a lamination over the muscle. If you go down deeper onto the bone, there is again a lamination called the periosteum, which is again a blood supply to the bone and also a protective layering, right? So let us discuss each one of them one by one. So on the face, you have a lot of muscles on the face, right? How do these muscles differ from skeletal muscles. As higher animals, we tend to express our emotions through these muscles of facial expressions. But if you look at this face, you would also see certain other muscles as well. These are the muscles of mastication. So if you look at the face, you would wonder what role would a temporalis muscle and masseter would have on the face. It does change the structural anatomy of the face. Somebody having very massive masseters would have a squarish face, right? So when we look at any treatment protocol with neuromodulators or myomodulators, we also intend to correct the structure of the face, right? And there we have to address the muscles of mastication as well, right? But how do these muscles differ from the facial muscles of expression? See, as there was evolution and we as higher animals had to express our emotions, there was an interplay and there was a change in the cervical fascia which got functionally modified into muscles of expression, right? And that is why you have a lot of muscles on the face supplied by the facial nerve, while the muscles of mastication is supplied by the trigeminal nerve, right? So there is a difference in the nerve supply and there is a difference in how they act. The muscles of mastication start from the bone and help the other bone to move. It helps you to open your jaw and close the jaw. But what happens when a muscle on the face contracts, right? When you want to be surprised, you raise your eyebrows. So there is a vertical folding. When you smile, your zygomaticus major, minor, risorius, they tend to pull your lip up, the angle of the lip up, and you end up having a little bit of crow feet here and there, right? When you squeeze your nose, your transverse nasalis, they tend to bring in those bunny lines, right? When you're angry, you see those angry 11s, right? Those are the corrugators actually pulling things in the center. So when we talk about the facial muscles of expression, it is basically a balance. It is a balance between elevators and depressors. So there are muscles which are elevating certain areas and there are muscles which are depressing certain areas. But at rest, while you're sleeping, I don't think many of you would be very angry while you're sleeping, right? You will be at rest. So whenever there is a contraction, the dynamics of expressions come into play. And you would notice that whenever there is a folding or there is a wrinkling, it is usually at the long axis, perpendicular to the long axis of the muscle. So if you look at the occipitofrontalis muscle, it is a vertical arrangement, and when you are surprised, when you raise your eyebrows, the wrinkles happen perpendicular to the long axis of the muscle, right? So this is how the wrinkling happen. So to look forth into how to correct these problems, you could either look at the mountains or you look at the valleys. So when you look at the mountains, right, you tend to calm them down by neuromodulators like botulinum toxin, and you fill the valleys with fillers, right? That's how we roll. That brings us to the next anatomical area. That is the skeleton. Now the interesting part about the skeleton is the facial skeleton is divided on the basis of ethnicity. Not all of us would have a similar structural alliance with a skeleton. So there cannot be a fixed protocol for each one of us, right? An Australian Aborigine or a European would have a different treatment protocol with an compared to an East Asian, right? In Asian populations, there are differences in anatomical structuring. So if you look at it, if you look at the sagittal contouring, if you notice this being the East Asian population, you will look at the piriform fossa, the nasal fossa. You'd see it is different from an Australian, African, or a European. So sometimes a generalized protocol doesn't work with each one of us. So here, the anatomy of ethnicity comes into play, right? If you look at an East Asian face, you would see the sagittal contour is more arced, right? You look at the facial profile, it might be medium to flatter profiles, right? The chin projection would be moderate. The orbital form is more or less roundish, right? The brow ridges are reduced to absent. So the brow ridges are not so prominent. And that is the reason why the lid, there are no double lids in case of Asians. We do a different kind of a blepharoplasty, right? The Asian blepharoplasty is different in the sense that the lid doesn't attach to the levator palpebrae superioris, the muscle on the eyelid. So when we do surgical blepharoplasties to create those lines where you can put in some eyeliner, we need to do a different kind of a blepharoplasty for you. So similarly, when we are doing a non-surgical protocol, we have to do a different technique for it, right? The nasal profile is concave. So most of us in Southeast Asia have a concave profile. So most of us would like to go in for rhinoplasties or for non-surgical rhinoplasties. It's very prevalent in this part of the world. And then nasal opening is narrow to wide. So all of this being said is a normal skeletal feature. If you bring in the aging perspective into it, it is a multifactorial process. It might be intrinsic and extrinsic. I'm not getting into the details of it. But most of it, you would see that there are changes throughout the layers that we discussed. There will be textural changes on the skin. There will be sagging of the fatty compartments. There will be changes in the skeletal, skeletal arrangements. So you will have a lot of things changing. But what led to the understanding of various spaces that we know of these days is the evolution and discoveries in the aging phase. So according to this particular journal of facial plastic surgery, we would see that even to date of 2013, we are finding newer spaces due to the advent of magnetic resonance imaging. From the 1800s, you would see various world wars have happened. There are various discoveries, and hence there are various anatomical findings to all of the above. So that helps us to think whether or not will there be a time when the surgical facelift would become obsolete, or is it something like non-surgical facelifts are going to take over the surgical ones? This brings me to the next important part. After the discoveries of various aging face, we came to know about certain areas or septas on the basis of certain retaining ligaments. And these are the ligaments which are responsible for certain treatment protocols that we go ahead with. So if you look at the lateral side of the face, starting from the top, you look at the temporalis muscle. So there will be a superior temporal septum and an inferior temporal septum. Around the orbit, there will be an orbital retaining ligament which passes laterally to the lateral orbital thickening. Underneath it is your zygomatic bone. On the zygomatic bone, there are zygomatico-cutaneous ligaments which fall back towards your zygomatic arch. And here, because of the vascularity and because of the structuring, this particular area is also known as the McGregor's patch, right? This becomes a robust structure on which you can actually count, right? If you want to hang on to this particular area, this is a robust area because it is attaching itself to the bone, to the periosteum. So it can cling on to other structures and pull things up, right? Just inferior to that, you would find the masseter muscle. So there are masseteric cutaneous ligaments, there are mandibular ligaments, there are other mandibular septum, right? So if you arrange these ligaments in a straight line, you would find that they would create a semicircular line, right? And on the basis of this, if you look at the arrangement of that sandwich that I spoke about in the beginning, it sounded like all the layers are differentiated from one another. But after the advent of these ligaments and after the advent of magnetic resonance imaging, we came to know that these particular arrangement are not so distinct. So anything medial to this line is more or less like those tiles on the roof. They are interspersed with each other, right? They're not properly distinguished between various layers as we discussed, right? And if you go ahead lateral to this line, right? If you're lateral to this line, you would find that the arrangement is like onion peel, right? You will have a segmental skin, subcute, mass, muscle, and so on. So this became a basis of surgical facelifts because you could actually venture into a certain plane and go ahead with the surgical facelifting, right? But if you were to do it medially, it would be impossible to separate out the layers. So how does this clinically help you in non-surgical? The clinical relevance is that anything that you do medially to this line would create volumization, right? And anything that you inject lateral to that line would create lifting, okay? So that is the function of arrangement of various layers. If you look at this coronal section, you would see every muscle, every gland is being covered by a certain layer, and based on its anatomical location, it is called something else, right? It is not the same. This mass does not exist on the neck. It does not exist above the zygomatic arch, right? So what perceives as a deep cervical fascia, which starts divided into the multiples of 2, covers the submandibular gland, goes up to the angle, right? Then divides and covers the masseter muscle, goes up to the zygomatic arch, and over it there is a layer called the mass layer, which is above the parotid gland. So to say, every important structure that you see is underneath this mass. So as long as you're not violating this mass, you are safe, right? The moment you go beyond this mass, you will open the Pandora's box, right? You will have all the neurovasculature, you will have the salivary gland, duct, cysts, everything, right? So as long as you have an understanding of where you are safe. Then of course, with the aging, there is change in the osseous structure, there is a widening of the orbital orbit, there is a widening of the orbit, there is widening of the pyriform fossa. The jaws, they also undergo a resorptive process, atrophy. And because if you chop off the legs of this particular table, what will happen? The cloth will start sagging down. That is exactly what happens when the skeletal structure, it becomes atrophied, the skin becomes sagging. So all of these postulations adds up to the injection anatomy, and it lays its foundation on 8 points, out of which 5 points are the bony points, and the 3 soft tissue landmarks are there. So on these bases, if you look at the topographical landmarks, this helps you or this guides you throughout your treatment plan, right? So what are these areas? This is the temporal crest, the orbital rim, the inferior maxillary border. What are these? These are your pyriform fossa and your gonial angle. So if you look at the soft tissue landmarks, there will be a medial iris, lateral iris, and the anterior border of masseter. Now, what is the most dreaded complication that you look into when you're doing injectables? I would be telling you each one of them in a very small duration, because we already have a paucity of time. So, most important thing is to understand the arterial supply, because on the face you have both external and internal carotid artery supply. Most of it is supplied by the external carotid artery branches, and there is anastomosis. If you see, it goes intracranial, comes out of the orbit, and there is an anastomosis with the external carotid artery branches. So anything which goes bad anywhere on the face can traverse back to the areas and cause problems, right? So if you look at the face is mostly supplied by the branches of facial artery. Facial artery arises from the antero-inferior border of the masseter. It is a tortuous artery, so it's hard to actually save it all the time, right? The course is such that it jumps in, dives down, jumps up, and so on. So you look at the course of it, then you'll find that at a point it is deep into the lip, but as it goes on to the nose, it starts to become superficial, right? So all of this leads to a complication known as intravascular occlusion. Most of the times it is because of the arterial occlusion. The reason being, whenever there were biopsies done in the areas of necrosis, it was found that the arterial occlusion was present. Why does it not happen with the veins? Is that the venous capillaries start from capillaries to venules to larger veins. But in the case of arteries, it is opposite, right? From a larger arteriole, it will go to finer capillary network. So there are higher chances of getting vascular occlusions, right? So when you look at a particular area of interest, there are a lot of things that come into play when there are vascular occlusions. They might be because of the direction of the needle that you're holding on to, then the pressure with which you are injecting, the way the plunger is moving. Basically, the systolic pressure will be more while it is flowing normally, but while you're injecting and you are into a vessel, that pressure will supersede the pressure of the blood, and hence there will be a anterograde occlusion of the filler. While you stop injecting, the flow of blood will start resuming, and hence you will find that the area where you have injected is not having any kind of occlusion, but you see there is blanching over the forehead. Meaning to say that it is not area specific. Doesn't mean that you occlude an area where you're injecting and there will be blanching in that area. It might happen in a distant area as well. Meaning to say, if you look at this picture, while injecting into, say, a nasolabial fold, you might enter into an angular artery, and it might go in and anastomose with the internal carotid branches. It might reach the central retinal artery and cause blindness. And you would see that over the course of time, post-COVID, there have been a lot of cases of blindness, right? Because a lot of weekend courses are happening. This particular entity of injectables needs a very good training and a long follow-up to understand how it works. So this is irreversible. So to say that if something like this happens, then you would probably require a microvascular surgeon to correct this problem. So you wouldn't want to get into a problem like that, which would bring us to certain case discussions, and I would want you to guess what has been done in a particular case. So in this particular case, you would see a lot of changes have happened, and if you look at it, I would take into consideration one by one as to what was done. So primarily, if you look at the forehead, there would be changes around the frontal areas. The two stars that you see here are basically supratrochlear and supraorbital. Supraorbital being transmitted out of the supraorbital foramen, and just 8 to 12 millimeters medial to supraorbital is the supratrochlear. So the point is that this particular nerve and arteries, they are deep into the periosteum when you are actually injecting it. So there is a no-fly zone when you are actually correcting this area. You want to stay away around 1.5 centimeter away from the orbital margin whenever you are treating this area. So if you look at this particular safe zone, if you go up looking at the tail of your eyebrow and you look at this temporal fusion line, it is 1 centimeter onto the temporal fusion line and over 1 centimeter. So this particular area is more or less safe for injecting, right? Somewhat like this. So in the beginning, we started what kind of depth should there be. In this particular case, you can address it by two different ways. One is to start inferiorly, where you would be superficial because the nerves and neurovascular structures are more deep. And while you are doing it from the top, from the superior portions, you need to be deeper. Okay? So it should be a subgaleal plane when you are correcting it from the top. So what else do you see is being corrected? The other things that you see, you can see the changes in the periorbital region. There has been no use of toxin, right? So the eyebrow has been lifted, and these are the 5 steps that you take to correct this kind of a problem. Basically, you use a high G prime product at the head of the eyebrow. Then you use an intermediate G prime for the body of the eyebrow. Then you correct the infra-brow hollowness with again a more flowing material like lesser G prime. And then again a higher G prime for the tail of the brow so that you have some kind of an elevation at the tail of the eyebrow. And again, if you want to correct the temporal hollowness, if you look at this, temporal hollowness has been corrected, then you have to inject it with an intermediate or a high G prime product. The next case would be the correction of the marionette and the nasolabials. If you look at the thigh population, you would find that this is the incidence of the facial artery running up. If you correspond to the nasolabial fold, you would find that in 42.9% it is medial to the nasolabial fold, in 23% lateral to the nasolabial fold, in 14% it crosses both sides, lateral and medial, and from medial to lateral in 19.6% of cases. This is particularly in thigh and Korean populations. So how do you go about it? There are certain areas of injections, initially a subdermal, more superficial plane, then you go to a deeper injection into a nasojugal groove, and so on. And then you go into a deepest part, that is the nasolabial fold, deepest part of the nasolabial fold. Then again, if you look at this particular picture, you look at the medial area, changes in the medial area of the under eye, then you would find that there has been a correction of this area as well. So you enter into the pre-zygomatic space from the zygomatic area, and then you inject through a cannula and correct this nasojugal fold. Which brings us to the next case, that is corrected with, what do you think has been used here? The last case, there was no toxin used, right? In this case, there was no toxin used. This is like half an hour before and after, right? But if you look at this case, these are 14 days apart. So here, of course, there is a use of neurotoxin in the frontoglobular region, in the orbicularis oculi, but there is a change. These are not spot injections. Here, the injectable anatomy is being utilized to attend to various neuromuscular bundles, which are the motor end plates. So there is a new publication which talks about retrograde versus spot injections. So you can also use a retrograde technique to actually cover more areas of the orbicularis oculi rather than doing the conventional spot injections. All right, this brings us to another case. The initial geometry of the face is more squarish. As it progresses up, it goes down to a more longer face, and there is tapering of the face. What do you think has been done in this case? So you see there are changes in the masseter. So masseter hypertrophy has been corrected, and a lot of other things on the face, as you're suggesting. The under eye area has also been taken into consideration. So if you look at the masseter muscle, it has superficial, medial and deep fibers. You draw a line from the angle of the lip all the way to the tragus, which basically marks the risorius muscle. Remember that risorius muscle also attaches itself onto the masseter. So if you are too anterior while injecting, you might inject into the risorius, and the patient might have an asymmetry while smiling, because risorius is also helping you to smile. So this is the kind of deviation that you see. These are the patterns in which the risorius attaches itself. Then this is a case of gummy smile. Again, you palpate the levator labii superioris echinacei, right, and inject 2 units into it, and this is what you get in about a week's time, right? Then the most commonly used non-surgical rhinoplasty, again a very satisfying procedure. You have to be careful of the columnar arteries. Again, you see as we go progress on the top, you would see it is getting superficial. So this is the usage of cannula. I use the cannula technique most of the times. The plane of injection is usually suprachondral and supraosseous, right? But what you need to be beware of in Thai populations and the Asian population, there is a presence of intercanthal veins. So when you are using the teardrop method with a needle, there are higher chances of actually injuring this vein. So this brings me to the end of the presentation. If there are any queries, I'm open for any questions. Thank you.
Thank you, Dr. Ali, for a very insightful lecture about the anatomy of injection. So is there any question from the floor would like to ask Dr.